This is number 2. Like, nevertheless, she persisted. My name is Lucy McBride. I'm a primary care doctor in Washington, D.C., who's interested in addressing the whole person. And what better guest to have today than Dr. Lauren Streicher, who's here, take 2, for our discussion about menopause hormone therapy, sexual health, and the WHI. So, at the risk of repeating everything Lauren just said in such eloquent phraseology, we're going to talk about the Women's Health Initiative. I want to point out the arguably the most important point you made. It was not a bad study. It was a very well done study. It was the first ever randomized controlled trial done on menopausal women studying the effects of hormone therapy. It was halted early in 2002 because there was a signal that scared the pants off of generations of women, suggesting that it causes breast cancer. Lauren just broke it down. The estrogen-only arm, that is the cohort of women who took estrogen alone, actually had a reduced risk of breast cancer. The women who took estrogen and progesterone together, those 2 hormones together, had an increased number of breast cancer cases, but as on an absolute level, it was 1 in 1,000. So this
Very, very small.
is very small, and the breast cancer mortality was actually reduced in those people. So here we are 20 years later, still trying to undo these fear-based messages about hormone therapy. It is not true that every woman should be on hormone therapy at all.
No, it is not.
No, and I want to talk about who shouldn't be on hormone therapy, but I also want to break down the word should, because I think we do a lot of shoulding in medicine. We do a lot of gatekeeping. We do a lot of like, no, you can't. Yes, you can. It's not about can you or can't you. It's about what are the risks of the hormones and what are the risks of not taking the hormones. And so can you talk to me, Lauren, about Dr. Streicher, Northwestern professor and sexual medicine expert, about who should not take HRT in your opinion?
Well, really what it comes down to is when a woman says to me, should I take hormone therapy? Shouldn't I take hormone therapy? It comes down to what are your symptoms? What are your goals? What is your medical history? That's where you start. And then based on that, you go from there. Because right now we have a lot of women who are feeling like, I missed out. This is so unfair. I'm screwed because I came of menopause age after WHI. I was never offered hormone therapy. Now I'm 65 years old and oh my God, I'm going to get dementia and heart disease and die early of a horrible death. And nothing could be further than the truth because and then they want hormone therapy. And so, to that woman, I say, okay, are you having any symptoms now? No, I'm not. What is your goal? My goal is to not die of heart disease. Okay, let's talk about how you're going to make that happen. And then we go on and talk about all the things that you talk about every single day of your life, ditto dementia. So, this idea that you have to take hormone therapy and you've missed out is simply not true. But on the flip side of it, when you say, who should be taking hormone therapy? And I'm going to back that up a little bit and say, who should be doing something about their symptoms? Let's start with hot flashes. When I was early in my training, the mantra was, it's a hot flash. No big deal. Dress in layers. Use a fan. It'll pass. And now we know, first of all, it doesn't pass all that quickly. Average length of time for hot flashes is 7 years. In Black women, 10 years. 10% of women, it's lifelong. Hot flashes are not a flash. They are there for a long, long time. And they're debilitating the quality of life, the inability to get a decent night's sleep, which we know also impacts on long-term chronic disease. But here's the thing. We now really appreciate the fact that hot flashes are not harmless. Every time someone gets a hot flash, there's a little rise in their heart rate, in their blood pressure, a little surge of cortisol, a little bit of an inflammatory response. And if that's persistent over time, we know that there is going to be significant damage to the cardiovascular system. So if you were to say to me, okay, who should take hormone therapy? Well, at the top of the list are women who are having hot flashes that they should either do hormone therapy or one of the non-hormonal alternatives, the neurokinin inhibitors. We could talk about those a little bit because those are new and very, very interesting. But the point is do not live with these hot flashes. These hot flashes are not good for you. And, a lot of times people will say, well, gee, does everyone destined to get heart disease and all that? They don't. And no, but we do know that women who have hot flashes are at higher risk, even when you would account for all the other risk factors that we know about. The flashers are different, and we think it's because of these longer term issues, and the insomnia, which is my second reason why people should take hormone therapy, because you gotta sleep. We have very, very good data that shows that women that persistently get less than 5 hours of sleep over a long period of time are at a significantly higher risk for cardiovascular disease and stroke. And when we think about sleep and menopause, and we could talk about that for hours, yes, hot flashes are on the list, but it's not the only thing on the list. There's so many reasons why women don't sleep. I mean, first of all, the same area of the brain in the hypothalamus that's our temperature control center is right next door to the sleep center. So we now know that even if people don't have hot flashes, they're going to have a disruption in sleep. And then we get the women who are now suddenly having all the joints, aches, and pains. That's going to keep them up. Sleep apnea. Sleep apnea goes up postmenopause. Why? Because there's estrogen receptors in the muscles in the back of the neck that get a little looser. So we always think about sleep apnea as that woman who's, the overweight snorer. Not necessarily. So the list goes on and on and on. So why do you take hormone therapy? To get a decent night's sleep, to get rid of those hot flashes during perimenopause, to help with those mood swings, to help with that brain fog. Those will go away, by the way. The brain fog is not an indication of dementia. It's just your brain getting used to its new hormonal status. The brain's amazing. It figures it out and it does get used to it. But to get through that period of time, which could be years, we talk about hormone therapy. And we're right now, by the way, we're talking about systemic hormone therapy.
Right.
Topical, local, vulvar, and vaginal hormone therapy is a completely different discussion.
I think that's
And
an important distinction. I think, you know, it's been wonderful to see the FDA, regardless of your politics, remove the black box warning on vaginal estrogen products. The black box warning should never have been there in the first
it's never been
place,
there.
because vaginal estrogen, local estrogen delivered to the vaginal and urogenital tissue doesn't is pretty harmless.
Right.
It's over the counter in the UK. Um,
It's not pretty harmless. It's
it's har
harmless.
it's
And you
harmless.
know what? And I don't say that easily, because most things you're gonna find, honestly, there's never been anything reported with women using
Right.
30, 40 years worth of local vaginal estrogen. And as you started off before you froze, talking about recurrent urinary tract infections, recurrent urinary tract infections are not just an inconvenience.
Well,
We
I think that yeah, I mean the absence of estrogen vaginally and urogenitally is responsible for so many symptoms: urinary urgency, frequency, more frequent UTIs, pain with intercourse, just
inability to have an orgasm.
yeah, pelvic
Yeah,
floor dysfunction. So, I think one of the reasons why women have tolerated the sort of narrative that hormones are bad for you is because we're used to suffering and we're used to you know, I think people just got inured to this idea that, those parts of your body kind of just atrophy and are uncomfortable. But as I said before I got frozen, I was talking to a patient this morning who's 72 who had all of the genitourinary syndrome of menopause symptoms, finally went on vaginal estrogen, and, I mean, she feels, I wouldn't say reborn, but she feels like herself again. And
absolutely.
so, as my friend Rachel Rubin says, I'm sure you know Rachel Rubin, who says, it's like chapstick for your crotch. It's very safe. I mean, I have had some people have, like, allergic reaction to the carrier, but in general, it doesn't cause breast cancer.
No.
I mean, we don't even think that
No. And just
systemic
to
hormone therapy
circle
causes
back,
breast
because
cancer.
people are like, why was that label on in the first place?
Right.
The label was on in the first place because of what's called class labeling, meaning that the FDA required any product that has estrogen in it, because of what happened with oral estrogens, to have the same label. So all those things listed on the local vaginal estrogen box: blood clots, dementia, breast cancer. It's not like they used to think that happened in local vaginal estrogen, and then we discovered it didn't. We've always known that that was not the case. And quite frankly, there have been many of us, not just Rachel, but many of us who go back, further behind Rachel, who've been trying to get that warning off for
Years, for
years,
years.
because it never should have been there. And while we're on the topic of local vaginal estrogen, just so no one's confused, when we talked about the optimal time to start systemic estrogen being between, 50 and 60, with exceptions before and after that, local vaginal estrogen, you can start when you're
Anytime.
90, anytime,
Well, I think,
anytime.
as you said earlier, I mean, if I think about, I'm a primary care doctor. If I think about what my older women patients are hospitalized for, it's osteoporotic fractures,
Mhm.
estrogen, that's arguably the best and most robust benefit for, taking HRTs on your bones. Number two, urosepsis or urinary tract infections that you don't actually know you have until you're in the hospital with urosepsis. And so
And I'm going to add
it's a
one more
no-brainer.
thing to that.
Yeah,
How did they get those osteoporotic fractures? Because they're trying to get to the bathroom frantically and they slip and fall in their urine when they don't make it.
that's right.
Seriously.
That's
I mean,
right.
so it all ties together. When we look at women who are literally, I think there's 8,000 deaths a year in the United States from osteoporotic fractures, because when someone breaks their hip, there's a 1 out of 4 chance that actually may lead to their demise. How do people break their hips? Because they fall down. Why do they fall down?
Right.
Well, a lot of
Middle of the
times they
night.
fall down because they are trying to frantically get to the bathroom. They don't make it. They pee, they slip in their urine and they fall. And when the paramedics come, you think they're going to say, "Oh yeah, I just peed on the floor." They know, say, "No, I just fell." But it actually has been studied and it is a significant risk factor for hip fracture.
I want to answer this question some of these questions as they come in because they're very good and they're ones I get all the time from my patients. Can vaginal estrogen be used without progesterone? Absolutely. You only need to use progesterone if you're on systemic estrogen. That is estrogen that is in a delivery system that's delivered to your entire body. So,
And if you
system
have a uterus.
and you have a uterus, right? So, estrogen systemically is either through a patch or a tablet, and we still prescribe estrogen pet tablets. I still do. Or if you're taking it through a ring, not the estring, which is just locally emitted estrogen, but the fem ring. So you only need to be on progesterone if you have a uterus and you're on systemic estrogen. Now, I
Okay.
have some patients.
I have to interrupt you for 1 second.
Please, please, please.
Because when we talk about transdermal estrogen, everyone thinks transdermal estrogen equals patch. Absolutely not. We
True.
have many options. And this is important because, first of all, it's hard to get patches right now. Second of all, a lot of people don't like patches. They don't want to walk around with the Band-Aid on their belly. They don't want to walk around with that sticky residue. We have gels. We have creams. We have sprays. We have the patch. Sometimes the patch doesn't adhere. So I don't use the word patch. I use transdermal versus oral. And then you mentioned, of course, the vaginal ring, of which we have 2.
Yes.
S-ring is for local amounts of estrogen, and fem ring, which comes in 2 doses, is systemic.
I love it. I'm going to talk about for a minute. I'm going to talk about perimenopause. Perimenopause is the 7 to 10 year period that is in the before you actually reach menopause. Menopause is defined as the moment in time when your ovaries are no longer making robust amounts of estrogen and progesterone. It's
And
not.
never will again.
It's not right. It never will again. And it's not unless you take your ovaries out surgically, it doesn't happen in a split second. I think we've done a lot of disservice to women by saying that you're menopausal only when you've not had a period for a full calendar year,
Correct.
because you can suffer a whole lot in the 7 to 10 years leading up to menopause, and certainly in the year when you're going through that sort of last hurrah of menstrual cycles, such that you would benefit from hormone therapy. So we treat the patient, not the calendar.
Correct.
But going back to the perimenopausal issue, I'm bringing this up because a patient or a person just wrote in, if you're on a low dose birth control pill and most of your symptoms have subsided, you need additional estrogen.
No. Let
And
me explain this because this
yes,
is
please.
critically important. So
Yes.
while you were frozen, I don't know if you heard this part, but while you were frozen, what I was talking about is the reason that we use hormone therapy as opposed to HRT is we're not necessarily replacing it to making it what it was before. We're using appropriate amounts of estrogen, progestogen in order to alleviate symptoms. What's going on during perimenopause is a lot of people have this idea that your estrogen levels are gradually declining. That is not what's happening. Your ovaries are going like this. It is this crazy up and down. And in fact, estrogen levels during perimenopause are sometimes higher than they are in a 20-year-old. You'll get these surges. And as a result of that, there's all kinds of mixed messages that your uterus is getting. Really confuses your uterus, which is why you get this irregular bleeding and the brain fog and all of the other symptoms that people get during perimenopause. If you give someone typical menopausal hormone therapy, it will do nothing. It will do nothing. I always use the analogy, the wavy ocean, if you pour in a little water, those waves are not going to get any smaller. What you need to do in perimenopause is to say to the ovaries, you're confused, we'll take it from here. You suppress them using a low-dose birth control pill, which is hormones that are Even a low dose pill is going to be higher than those surges. It's going to suppress it and supply steady amounts of estrogen and progestogen to your body, which will take care of the crazy bleeding. It will take care of all the symptoms. It will take care of all of that so that you don't need to take hormone therapy, which is like throwing, a drop in the bucket of water. It will do absolutely nothing. You just take a low dose birth control pill.
Yeah, it's
One
basically
of the
like it takes over the driving. The birth control
exactly.
pill takes over the driving, so you're not ovulating and at risk for getting pregnant.
There's that, right?
And then also it's taking over the driving, so you're not a victim of the roller coaster of the estrogen levels, as you just said. So if your symptoms are mopped up, if you will, that's the expiration I often use to my patients on the birth control pill. No, you don't need more estrogen. We treat the symptoms, not
And I do not
sort of the
need more. It's not
cookbook.
going to do anything. It's not going to
Right.
do anything. Yeah.
That's right.
Yeah.
Okay, let's talk about the 10-year window. So
Yeah.
there's so much, even in my most intelligent, educated, informed patients, there's still a lot of confusion about this.
Mhm. It's
Here's what I tell
confusing.
people. So we know that women who start HRT within the first 10 years of their last menstrual cycle tend to do better on a population level. Meaning, if you take tens of thousands of women and put them into groups of, before tens of thousands of women who already are in that 10-year window of their last menstrual period. And you put these people on HRT and these people not on HRT, the women who took hormones tend to do better. But on an individual level, it depends on who you are as to whether you're going to benefit or whether the risks are greater than the benefits. So I tell my patients who are within that 10-year window, and we're talking about hormonal therapy, we're talking about their symptoms, that out of the gate, like the burden of proof is to show that you shouldn't be on hormone therapy right now. Like, we should put you on hormone therapy unless there's a reason not to. It doesn't, however, mean that at 61 or 10 years after your last period, you can't be on hormone therapy. It doesn't mean that there's a stop sign at 10 years such that all of a sudden your risk goes from like 0 to 60. It really depends on who you are, your underlying health conditions. And, it's important for people to realize that risk is on a continuum. Like, I think we have a very primitive, and even doctors have a primitive understanding of risk. It's not a on-off switch, it's a continuum. And so the best kind of physician or set of physicians you can have are people who understand how to contextualize risk and how to help you understand what risks you can't control, like family history, and what risks you can mitigate
Exactly.
with lifestyle factors. So I think in the popular press and in the public square, we are thinking in these binaries, like at 10 years, nope, you can't do it. Or if someone you in your family had a blood clot, nope, you can't take it.
Yeah.
When actually risk is very variable, and it takes a physician, not just like a chatbot or a influencer on Instagram to tell you what to do.
That's right. I actually had a recent Substack post, I think it was probably 3 weeks ago, that was 20 reasons you've been told that you cannot take hormone therapy that are not true. And I go through a lot of the things that you were listed, like the blood clot. Now, you can take it, but it has to be transdermal. And so before I kind of respond to what you just said, I think we have to very clearly differentiate between the woman who starts hormone therapy at the typical time and then wants to continue past the age of 60
Yes.
versus the woman who wants to start new after 60. Two completely different things. So just to kind of shorthand it, the woman who's on it and wants to keep on it generally is just fine. We're not going to talk about that right now. The question that people really have is, I haven't been on it. I'm 65 years old. I'm worried about heart disease. I'm worried about dementia. I'm worried about my bones. Can I start it now? And the answer is, it depends. It depends. Why do you want to start it? What are your symptoms? What's your medical history? So there's a very big difference between the woman who says, I'm 2 years old, and oh my God, I'm still having hot flashes, and I am still not sleeping, and my joints are still killing me. And then the response is, you know what? You may well benefit from hormone therapy, and now we need to make sure it's safe. So we're going to look at, what is your cardiovascular profile? What are your risk factors? Are you a candidate? And then figure out what we're going to give you. And if you're not a candidate, then we look at other options like the neurokinin inhibitors. But on the flip side, if you're someone that says, I'm 65 years old, no, I'm not having hot flashes, sleeping like a baby, feel really good, I just missed the boat and I want to start hormone therapy, the response is, it's probably not going to do anything for you. So let's address all the things you can do that I would tell any woman on hormone therapy or not to do to minimize her risk of cardiovascular disease and dementia down the road.
I love it.
One of the things I point out to women who get just so worried, and I understand why, because there's all these influencers out there saying everybody has to take hormone therapy. Look at the blue zones. They live to 100. None of them took hormone therapy. They don't eat processed food. They move. They are in community. All the things that we don't need to do that because you've already done that. That's what you do every single day. But the point is that this is not this silver bullet that is going to make
That's
everyone
right. That's
better.
right. And
But
I think
having said
it's a
that, and I'm not afraid of hormone therapy, and for a lot of women over 60 who might benefit, and I don't know if you know who Jim Simon is.
oh, yes, I know Jim Simon very well.
Yeah, so
I'm in
he's near
DC.
Washington. Yeah, so I've done a number. He's one of my favorite podcast guests, and I did a podcast with Jim specifically about starting hormone therapy after 60, and he's written a number of wonderful articles about it, and he really goes through the bullets of, okay, who's it going to benefit, and then what kind of evaluation are we going to do to make sure that it's safe? And it really comes back full circle to what you started off with saying about how you practice medicine that is nuanced. And menopause care is nuanced. It is not one size fits all. You don't give the same hormone therapy to everybody any more than a cardiologist would give the same antihypertensive to every single patient. You evaluate the person and then you talk about the pros and cons and decide. Have I started hormone therapy in someone who's 65? You bet. Have I told a lot of women who are in their 60s that, nah, you don't need to do this? You bet. It's
I think
very
it's a really
individual.
good point. I just want to point out two things. One is that I think it is very true that now that menopause is so commonly discussed, including right now, like, it's a very popular subject. It doesn't and maybe we've over-indexed on it such that women who have not taken HRT feel like they've missed the boat, and therefore
Right.
they are destined for dementia, osteoporosis, cardiovascular disease, and, you know, damn the doctors, and I don't blame them for feeling
I
that
don't
way.
blame them either.
But I
Yeah.
think we also need to realize that hormone therapy and the absence of estrogen, which is the definition of menopause, is only one feature of the female existence, right? So to reduce cardiovascular risk in a non-hormonal way, to reduce stroke risk without hormone therapy is what I talk about every day as a primary care doctor.
Right.
It's about managing your risk factors: cigarette smoking,
Absolutely.
diabetes, high blood pressure, high cholesterol, exercise, managing your stress. All those things are evidence-based ways to reduce your risk
Yeah.
for dementia and cardiovascular disease. So hormone therapy, it is so time that we talk about the facts and dispense fact-based information to women who've been deprived of information about their own bodies, but it doesn't mean that HRT is the end all be all. And I think
No.
the other point I'd love to make that you just said, I'd just like to double down on it, is that just because I may recommend to a woman, at 70 not to take HRT, and it's just a recommendation, it's not a mandate. It doesn't mean it's so risky. It means that it may just not do much. If
It's
you
not
don't
just
have
not fun.
symptoms, it's
Well, you
so
talked about bone health before, because I think we should
yeah,
spend a little. We talk a lot about cardiovascular, as we should,
yeah,
but sometimes we kind of forget about bones because that's the silent disease until someone has a fracture.
right.
And a lot of women are surprised to learn that most of their bone is lost pre-menopause. It's during that right before perimenopause, even while you're still menstruating, is when you start to lose bone. And one of the big problems we have is that most women get their first bone density, their first screening for osteoporosis at 65. It's too late. The bone is lost. The bone is lost. And it's very important that we start to think about doing what we can to have good bone health, starting, quite frankly, I mean, we're all past this, but if you've got kids, teenagers, grandchildren, a lot of people never even get to their normal bone mass because there's no calcium in their diet. They're sitting around instead of walking around and being active. So that, I think, is a really important point, that if you think you're going to help your bones by starting hormone therapy at 65, you are not. It's really it's too late. Now, we do give hormone therapy to help with bone health because it's gonna help stabilize the bone and not lose more, but what's lost is going to require something different than hormone therapy.
That's right.
And
Weight-bearing exercise, a calcium-rich diet, optimizing your vitamin D level,
that's right.
and, limiting alcohol, quitting smoking, limiting medications that, negatively affect bone density. So I feel badly for women who missed the boat, and I wanna say to them, it's not too late to have a conversation with your
Oh,
doctor.
no.
It's never too late to start HRT if you're willing to accept the risk and accept the limitations of HRT that come with age. As you age, you lose the receptors for the estrogen itself, so the benefit just may not be as great as it would be if you had
And
started
for
it.
honestly, for some people, it's not going to be at all. I mean, I think that's the
Yeah,
discussion we need to
that's r
have, just to say, you're not a candidate. Let's talk about what you're trying to accomplish and talk about how you're going to get there.
right. And then the other myth that's floating around there is that you can only take HRT for 10 years. So this is a conversation I had with a patient last week who's 49 menopausal. And she said, I read online that you can only take it for 10 years. So I'm kind of thinking maybe I should pick 51 because that. And I said, oh, whoa, 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 whoa. Stop the presses, stop the presses, stop the presses. The 10-year window, again, I want to shout it from the hilltops, means that women in general tend to do best when HRT is started in the first 10 years after their menopause initiation. It doesn't mean that you can't continue it for 11, 12,
Yeah.
25
And in
years.
fact, it's so funny because some people have heard this mantra of take the smallest amount for the shortest amount of time. That was never based on any scientific evidence. It still isn't. The Menopause Society that I'm very involved in, even they're really conservative. They don't even say that. It's like you can take it as long as you want. It's really an individual thing. But the study that I think is so interesting, there's been a couple studies, but one that came out with 10 million women in it who started at the regular time, when they're in their 50s, and now they were in their 60s, 70s, 80s, and even up to 90, and they had continued it, and they looked to see how they did. And they were doing very well. And in fact, they had less cardiovascular disease, less diabetes, less of some kinds of cancer, and nobody was doing worse of the people who stayed on it. So that's a different discussion of do you stay on it? And one of the things they asked in this study was just kind of well-being, like, how do you feel in general? And I'm thinking that was because they didn't ask about sex. All these people who are saying I stayed on it just because I felt better, they're saying it's, yeah, because it helped me in terms of my sexual function, my libido, and all of that. But the number one thing when I was practicing during WHI, and we talked about the flush heard round the world when all these women flush their estrogen, and we expected the hot flashes, right? We expected people to come in and say they weren't sleeping. But what I didn't expect that surprised me was the women who came in complaining of joint pain. And at that time, I was not a menopause expert then. I was new in practice, and I thought it was coincidental. I'm like, "Oh, you're just getting older. Now you're getting arthritis." And they're like, "No, really. Ever since I went off my hormone therapy, I can't even play tennis anymore." And now, of course, I know and I appreciate the fact that estrogen has a profound effect on not just our bones, but also our muscles and our joints. And for a lot of women, that's why they continue, so that they can stay active, so that they can keep moving. So again, nuanced and individual. If someone comes to me and says, I'm 65, I'm 70 years old, I want to stay on my hormone therapy, that's a discussion. You say, okay, let's talk about what your symptoms are, why you would like to do that. And I never take anyone off their hormone therapy unless I have a very good reason to do so. There's
Let's
we
let's
don't
talk
have the
about
science to back it up.
let's the other common question I get, and I know you get this too, is my mother had breast cancer and my grandmother had breast cancer. Is it true that I can't take hormone therapy? So talk to me as we started to talk about this and then I got frozen and then we had to start over.
Okay.
Talk to me about breast cancer in the family, which to me just means you have women in your family unless you're unless you have a BRCA gene. And then talk to me about breast cancer survivors, women who have had breast cancer, who had to go off their HRT, or if they were never on
Right.
it, are told they can't take HRT.
Okay, so we're talking two groups here. We're talking women who are either at high risk of breast cancer or perceive themselves to be high risk of cancer. That's one group. And the second group are women who are living with a breast cancer diagnosis. So let's talk about the first group first, because that's easier. When we look in terms of is taking hormone therapy going to increase your risk of breast cancer, the answer is no, based on the WHI with conjugated equine estrogens. with a bioidentical estradiol. We only have observational studies, meaning going backwards. But having said that, we don't have any studies that show an increase in breast cancer. It's at best at breast neutral. But this is where it gets interesting. You mentioned women who have a BRCA gene mutation. We know that of women who are at risk for breast cancer, the group that is dramatically at the highest risk are women with a BRCA mutation for breast and ovarian cancer. And because many of these women end up with prophylactic early removal of their ovaries, very often they go through a dramatic, sudden, early menopause, the worst kind in terms of symptomatic and risk of problems down the road. This is a group that's actually been well studied, include a new study that just came out in which they gave women, now, just to be clear, these are not women with breast cancer. These are women who are the highest
Highest
risk for
risk.
breast cancer, and they were given hormone therapy. And what they followed for 7 years in this last study, that there was no increased risk of the development of breast cancer in this extremely high-risk group. But in the new study that just came out, and I don't know if you saw it because it's pretty new, the new study that just came out, they actually looked at different formulations to see if there made any difference. In no formulations was there an increase, but there was one that there was a decreased risk of breast cancer. And that was, and I don't work for this company, I always like to make these disclaimers. There's a drug called Duave, and Duave is a very interesting combination hormone therapy that is conjugated estrogens, but instead of a progesterone, it has a progestogen alternative called basodoxifin. And basodoxifin is a selective estrogen receptor modulator, meaning it's a class of drugs that either activates estrogen receptors or blocks estrogen receptors. Everyone's heard of tamoxifen. Tamoxifen blocks estrogen receptors in the breast. Well, basodoxifin is a cousin to tamoxifen. It blocks estrogen receptors in the uterus, which is why we can use it as a progesterone alternative, but it also blocks estrogen receptors in the breast. So when they gave these women with a BRCA mutation this particular product, Duave, which is available, it's a prescription product. It's an oral estrogen and basodoxifin. There was actually a decreased risk of breast cancer. And we've seen, so there's other studies with this combination as
Are you
well.
saying you're saying decreased compared to the average person with the BRCA gene, not decreased in the general population?
I'm talking about decrease compared to the other hormone therapy users. This was a study where they had, I think there were 3 different formulations they gave. No one had an increase, but the ones that actually had a decrease over the general population. Now, the other thing about this combination, this, and I do have a Substack article on this. The other thing about this combination of conjugated equine estrogen and basodoxifin is there was a study where they gave it to women with breast cancer. This was a multi-center trial of women that had a biopsy that showed a ductal carcinoma in situ, so very, very early. And normally these women would have a lumpectomy. But instead of the lumpectomy, they said, we're going to have you wait a month or two. And these were breast surgeons giving their patients estrogen. Think about that, everybody, right? So they gave their patients this combination, and then they went back a month later and they did a biopsy and they looked for the markers that show the activity from the cancer. And it was like gone. And it's like, oh my God. And I'm not saying that this is treatment for DCIS. I want to be clear about that. But the point is that we have a number of very good studies that show that estrogen with this particular combination can actually decrease the risk or decrease the activity. So again, to circle back to like put a button on this whole thing, this idea that estrogen is going to increase your risk of breast cancer really is not based in good science. And in the WHI, it was only the group that was taking the synthetic progestin, the medroxyprogesterone acetate, that had a slight increase. So then we get to group 2. That's a little more nuanced. Women who are living with a breast cancer diagnosis. And so, there's different kinds of breast cancer. There's ones that are estrogen receptor positive, and there's ones that are estrogen receptor negative. And the estrogen receptor negative, we actually have a fair amount of data, observational, meaning that we're looking back at women who were given hormone therapy who have an estrogen receptor breast cancer. And in most of these women, it does not seem to be increasing their risk of recurrence. It doesn't really change their prognosis. We do not have as much data in the estrogen positive group. Everyone's afraid. Everyone's afraid. They think it's going to be like fertilizer to their cancer. One of the things that I would recommend in terms of all your Substack, do you know Corinne Menn? Dr.
Yes, I
Corinne Menn?
do. I do. She's
Yeah.
terrific. She's
She's
terrific.
wonderful. She's a dear
Yes.
friend of mine, and Dr. Corinne Menn, you should follow her on Substack, and she's been my guest many times on my podcast, and we hang out a lot. We're at a lot of panels together, and she herself is living with a breast cancer diagnosis and has really devoted her life to giving good information to women. And she has a number of articles, and I have those lists of articles too on my podcast show notes that look at all of the studies of women with breast cancer who've received hormone therapy. So my bottom line message for women who have a breast cancer diagnosis, whether it's remote or current, and are wondering about hormone therapy, is it's nuanced, it depends, it's shared decision making, but it's not an absolute no.
I love it. I have a patient, you have many patients like this who had breast cancer, estrogen receptor positive, progesterone receptor positive. It was 10 years ago. She took tamoxifen. She she then decided, because she didn't want to worry about cancer, she had a mastectomy because she just was so worried about it.
Yeah.
So this is 10 years out. She doesn't have breasts.
Which would make her very low risk for breast cancer.
So she's coming to me saying that her oncologist is saying, "No way, Jose, am I going to put you on estrogen." And would she let someone put her on hormone therapy? And I said, "Well, I understand that POV, but you're 10 years out and you do not have breast tissue. Could there be a stray breast cancer cell in your body somewhere that got loose and has nestled itself in your some other organ, and that giving you hormone therapy would awaken it?" Yes. But what I would hate for you to do is have 20 more years of
Misery.
misery, joint pain, pain with sex, although we can fix that with
Although
the
the law,
vaginal
just to be
estrogen.
clear,
Vaginal
vaginal
estrogen,
estrogen can be used in any woman with a breast cancer diagnosis, even if she's taking an aromatase inhibitor.
correct. So I put
Any
her on, so she's on that, but she still has the achy joints, the brain fog, and
Mm.
she still gets an occasional hot flash. So I said, look, there's no right answer. There's no like, and if I knew you'd never get recurrent breast cancer, this would be a no brainer. You would have been on it like from the get go. So it's really up to you as to what your tolerance for risk is and what your screenings are. And she decided to try it, and she feels a ton better.
Of course, of course. Yeah, I mean, that's exactly the point, is you can't make any blanket statements because it is nuanced, and there are so many variables that are gonna impact the decision, and it's a decision. It's a
That's right.
decision. But there's a difference between the absence of data and data that shows that it's a problem. And quite frankly, when it comes to women breast cancer and hormone therapy, we are dealing more with the absence of data than we are data that, I mean, that's the thing. People have this idea like, well, everybody knows that if you take hormone therapy, you have breast cancer, that you're going to get a recurrence. No, we don't know that. In fact, that's never been shown. So I do every once a month for my Substack subscribers, and I see a lot of questions coming in. I do an Ask Me Anything webinar. And I just did one a couple nights ago. In fact, after I get off of this, I'm going to be posting my Ask Me Anything webinar for my subscribers. And people just like this, I just sit there and answer questions for an hour. And I cannot tell you how many questions were specifically about that, just on a regular basis every year. And in fact, someone during this last webinar said, well, if someone hasn't had a mammogram, would you give them hormone therapy? And I said, well, I think every people should have a mammogram because it's important to have a screening mammogram. But do I think giving them hormone therapy is going to accelerate a breast cancer that exists? We don't actually know that. We
Right.
really don't
Yeah,
know
get a
that.
mammogram, but not because
Get
I'm
a
starting you on
mammogram.
HRT.
Right.
Really quickly, Lauren, someone's asking a great question about formulations of estradiol. To me, the highest yield change I have made in the way I prescribe vaginal estrogen is not, estrase versus another sort of brand name, is really the application of it. So
Absolutely.
for a long time, I was doing the wrong thing. I was telling people, I've been prescribing vaginal estrogen forever, but I was telling them to use the applicator with the cream and just shoot it up there in your vagina, and wrong.
Wrong.
you need to throw the applicator away. You put it on your finger. You put the vaginal cream on your
Just put a
finger.
whole strip on your
Put a
finger.
whole strip on your finger. Do not be shy about it. And then put it all around the labia, the external and internal labia, the urethra where your urinary tract ends, and then put it in your vagina like you're
But
putting
you're
on
forgetting one
sunscreen.
thing. You're forgetting one thing. You're at your urethra. What do you do now?
Your clitoris.
You go north.
You go
Yes.
north.
Do not forget your.
Put it everywhere. In other words, like you apply it. You don't just shoot it up there and walk away and then it's sitting
Okay,
in your underwear.
exactly. But I'm going to add one little thing to that. The majority of the estrogen receptors inside your vagina are in the lower third. Now, we were all taught as teenagers when you're using tampons, the higher the better, so it won't fall out, so you won't feel it, so you shove it all the way up there, right? Well, everybody thinks you're supposed to do the same thing with your estrogen cream. You're not treating your cervix. You're treating the lower third of your vagina. And quite frankly, not only are you going to get increased absorption, but the real issue is you're not going to get maximum benefit. And I have one episode of my Come Again series, my 30 episode audio series called I'm using vaginal estrogen, but sex still hurts like hell. And I address that specifically, in addition to lots of other reasons why that might be. But you apply it to the lower third of the vagina, and then on the vulva, as you said, the vestibule, which is that pink area, the opening to the vagina. It doesn't matter how nice the room is if you can't get through the door, and people forget to treat the vestibule, and then the labia, the urethra, and the clitoris, because the other thing people may not appreciate about vaginal estrogen, in addition to increasing lubrication and tissue health, is it increases blood supply. It's a vasodilator. And that poor little clitoris needs a little estrogen love because that's going to increase the blood supply, which in turn will make the nerves healthier and help with orgasm. So that's like, a really quick little tip on your estrogen. And I have a YouTube video on I actually throw the applicator away over my shoulder and then show, how to put the strip on and use my little vulvar puppet to show the application.
Yeah, sometimes it's the most simple interventions that
I just
empower
got a note that we
patients.
are both frozen now, which is
Oh, no, we're
interesting
both frozen.
because
Okay, we're both frozen.
you're not frozen. Did someone else weigh in on that? I don't know if it's that one person or if
You're both frozen now. Oh, Lord have mercy. This is just one of those days, but I think maybe the internet doesn't like us talking about sex. I think
clitorises.
that's maybe so. Lauren, I am gonna
No,
let
no,
you
now we
go.
have someone that says that we're okay.
We're okay now. Okay.
We're okay.
So
Not frozen. I think it was just that one. I think it was just that
I
one.
could talk to you forever. I could learn so much more from you. And frankly, I didn't learn anything about menopause, hormone therapy at Harvard Medical School. Zero, goose egg. So I have learned it on my own. I have, I am, like physicians were students forever, right? And so I just have taken it upon myself to educate myself by talking to people like you, talking to Rachel Rubin and Sharon Malone and Corinne Men. And
All my friends. We were all just
there's,
together for the premiere of a documentary came out called Balance. So Sharon and I were sitting next to each other in Hollywood at the
yeah, Sharon,
premiere, and Corinne, and I have a great picture on my Substack of Corinne and I walking down the red carpet together. So yeah,
it's
we
so
have a great
fun.
time together.
Yeah, and Mary Claire Haver actually wrote the foreword to my book that's coming out in August. There's so much great information coming out there. There's also evangelism that I want to be wary of doing because I think, as you said, it's not a magic bullet, and there are other ways to improve bone health, cardiovascular health, cognitive health, and prevent
Absolutely.
deterioration that are non-hormonal, which is a whole other separate episode here. But tell me where people can find you, Lauren Streicher.
I will. Well, first
Yeah,
of all, I'm going to mention, since you just mentioned Dr. Mary Claire Haver, I was on her podcast, I think it was 3 weeks ago, talking about orgasm. We did 2 segments, so that was a twofer. But I'm on Substack, of course, Dr. Streicher's Inside Info. And in addition to that, I have a podcast called Dr. Streicher's Inside Information that's on Apple, and it's free and no sponsors, and that's on every single platform. And then my big project that I've been working on that got released a couple months ago is called Come Again. You know what that's about? And basically, it's a 30-episode audio series that you just get it and you get the whole thing so that you can listen to it whenever you want. And it comes with all kinds of supplementary material and articles, and you name it, I address it. And what did we decide? We have a code for all of your listeners. It's going to be Dr.
Dr.
Lucy.
Lucy,
So
DRLUCY, is you can put that code in and you get like 30% off or something like that.
30% off, and it's not expensive. I think it's like $35 or something. I have another version for healthcare professionals if anybody's on there that really basically helps you set up sexual medicine in your practice. But for just people who just want to listen to this stuff, it's I try and make it as fun as possible. And once you get it, you've got the whole thing. So in order to come again, you go to my website. It's not on my Substack. You go to my website, Dr. Streicher. That's DrStreicher.com. Hit the Come Again tab on the homepage. That'll take you to the Come Again. You can see the list of all the episodes. You can listen to previews of the episodes. And then if you decide you'd like to get it, then when it asks for the code, when you purchase it, you just put in Dr. Lucy, DRLUCY. You will get 30% off. Don't do it yet, because I didn't get it. Give me 15 minutes after we get off to go put that code in, because I haven't put it in yet. And I'll keep that code live for the next 72 hours. And that's where you find me. So you can find me on Substack. You can find me on drstreicher.com.
Lauren, you are a treasure. You are changing hearts and minds and sex lives and women's health one woman at a time. So thank you for coming on the podcast. I cannot wait to talk to you on your podcast. I think we're doing in July to talk
We
about
are
my
taping in July about your new book. We just found out that we have one of the same. We both have books coming out with Simon and Schuster.
That's
And
right.
we share one of our editors we know the same person at AARP, which is I'm working in conjunction with AARP.
I
So
love it.
we actually have a lot going on together. So I think you're going to see a lot more of the Lucy Lauren show, right?
The Lucy Lauren show. We get a camper van. We paint the sides of it. We go on
Let's go on
tour.
the road.
Let's go on the road. I love it. The Lucy and Lauren show. Bring it. More facts, more nuance for more people, the better, right?
Absolutely.
It's a jungle out there. And thank you for being so easy, accessible, and conversational. It's been a delight
Right
talking to
back
you,
at
Lauren.
you. I love talking to you, and I love everything that you do.
Talk to you soon. Thanks everybody for joining. Bye. Take care.